So, the supraglottic airway, the iGel, is great, and we're all taught that this is the rescue supraglottic airway device of choice. But we find that it's often taught as a kind of foolproof device, ignoring the nuances of correct insertion and also size selection. So I was wondering if you could help us out today and just start really by clarifying for us where it's meant to go. Like where's it sitting? How does it work? We've got a mock larynx, an airway here. Could you talk us through where it's meant to sit?
Yeah, no problem. So the iGel is, I think as we know, it hasn't got any inflatable cuff or anything. It's just a device that's designed to sort of sit in the just above the laryngeal opening. So if you actually look at the iGel itself, this is the tip that's going to go down the esophageal opening. And if you can imagine the actual laryngeal opening just sitting where the sort of bowl of the iGel actually is. And we can see in this image, in this model here, that this is where the iGel is going to go. It's going to come around the corner. The tip of the iGel is going to go down into the esophagus, and it's going to sit nice and snug in there. Now, where the epiglottis is, it can vary. It can either be sitting just in the bowl itself, or if the iGel has gone in a bit further, the epiglottis will be outside of the bowl. To be honest, it probably makes a little difference as to where the epiglottis actually is. We use iGels for bronchoscopies in the operating theatre, so the patient is anaesthetized, the iGel goes in, and we put a bronchoscope through the iGel, and the view we get is really just of that laryngeal opening, with occasionally the epiglottis seen.
I'm curious as to what that would look like. Handily, we have our bronchoscope here. Oh, wow, that's beautiful, isn't it? So I guess we can see the posterior cartilages there quite clearly, which means they're snugly within the bowl, aren't they?
Yep.
Can't see epiglottis though, so that's outside the bowl.
Outside the bowl. So if I move the actual, if you stay where you are and I move the iGel back, you should be able to see the epiglottis there. If you come back a bit with the bronchoscope, there you go. There's the
there it is.
epiglottis.
We've got the base of the tongue there as well.
But as you can see, it makes, in many ways, little difference to the view that you actually get. So I can push the iGel back in a bit further, and then you can see that's the view that you get.
The epiglottis is visible, but most of it's outside, I guess. Yeah.
Yep.
Beautiful. So that's obviously fitting quite well. So we got the size right. Was that by accident or design? How do you select the right size? Because I know it's written on it, and the manufacturers do a recommended size based on patient weight, don't they? Is that what happens in the real world of anaesthesia?
We do look at weight, but often we would look at the patient as well. So as you can see here, we've got a 3, 4, 5 iGel. Now, the 5 iGel is recommended for 90 kilos plus, 4 for 50 to 90, and 3 for 30 to 60. In my experience, others may differ, but I generally find a size 5 will fit in most men, a size 4 for most women, and a size 3 is starting to go down to teenagers. So if you look at the different size of the actual green bowls here, you can see that there's the 5 and 4 are fairly close, but the 3 is quite small. So you may sometimes get more of a leak with a size 3 compared to a 4.
That's almost a gotcha, isn't it? Because look, 3 says 30 to 60 kilos, and there's plenty of 60 kilo adults around. Yeah, men and women. You can imagine a 60 kilo woman. In a hurry, you might pick this up if you're not very experienced and go, 60 kilos, she looks about 60, let's pop this in. And you're probably way too small for a lot of adults. And I guess for the bigger adults, let's say a woman who has a high BMI isn't necessarily going to have a big airway. You eat lots of food, you put on more weight, but you don't put on more airway, do you? So these are all interesting things to think about. If you just base it on weight, you can go wrong. So I like that as a general guide, 5 for men, 4 for women. Okay, so we know how it works, we know how to get the right size, but we've got to put it in correctly. And it isn't foolproof, is it? If you don't insert it correctly, you've got the danger of your iGel sliding down and actually pushing a bit of the tongue more posteriorly, or even folding a bit of the tongue back and not seating properly, and potentially even causing, a bit of obstruction there. So how do we optimize the correct sitting of the bowl over the airway in terms of our insertion technique?
Right, so if I could just grab a size 4 iGel there. So the issue with the iGel, it is fairly bulky, as a lot of supraglottic airways are, but the bulkiest part is this bowl area here, the actual mask bit of it that's going to actually go into the mouth. And if you're familiar with laryngoscopy, it's the same issues. So with laryngoscopy, what you're trying to do is to open up the airway so you can get a nice big space so you can pass a tube easier. Now you're trying to do exactly the same with an iGel, but how do you open up the airway? Well, there's 2 distinct phases, I believe. The first of all, you've got to get the mouth open, and then the second part is that you've got to do jaw thrust to allow that opening up of that airway passage. We work as a team in anaesthesia, as an anaesthetist and with an anaesthetic nurse or an anaesthetic assistant. So often what is happening is that I've got the iGel, and then the anaesthetic nurse is going to do mouth opening. So if you can just demonstrate that. So essentially by putting your thumbs over the mandible and just opening the mouth. And it's a very simple maneuver to do. You're opening the mouth, and now I'm going to put the iGel, the actual mask of it, into the mouth. And once that's in, the movement's now going to change to jaw thrust. So with thumbs on the maxilla and the fingers behind the angle of the mandible, you're now doing jaw thrust. That's opening up the airway, and that allows the ease passage of the iGel in. This is a mannequin, so it's a little bit trickier than the normal, but that's the basic idea. You're opening up the airway with 2 maneuvers, opening the mouth and then using jaw thrust to open up the rest of the airway.
That's great. And I love the fact that this is a 2-person technique for optimizing first pass success. When we talk about optimizing back and after ventilation, we put the pillow under there to get it several notch. We'll usually have the patient muscle relax, and we'll do 2-person technique, won't we? 1 person holding the mask and doing the jaw thrust, the other person squeezing the bag. Same with our standard intubation practice in our services, which is a bougie assisted intubation, which is generally a 2-person technique. And for this rescue maneuver with a supraglottic 2-person, again, optimizing first pass technique. I noticed I noticed that you have the patient optimally positioned again for the supraglottic with several notches. Is it just as important for iGels to do that as it is for laryngoscopy?
Look, I think the simple, if you're using this as a rescue technique, you need every advantage you can possibly have. So optimizing the patient position with all the usual ways that you would normally do it is going to be the ideal way to actually assess this.
Brilliant. Now imagine there's a few paramedics out there around the world that are going, oh great, you fancy Australians with 10 people on scene, including physicians in the middle of nowhere. I don't have that luxury, dude. I'm on my own with these patients. How am I going to optimize insertion with 1 pair of hands? Is it possible?
Sure, absolutely. I mean, if you think of the basic principles of mouth opening and then doing jaw thrust, let's try and do that as a single operator. So mouth opening should be fairly straightforward. You're just going to open the mouth either just this way, or you can use the technique of opening the mouth from the inside. The problem with this way is that it's going to be a barrier for the iGel to go in. So I think that the best you can do is opening the mouth by just pressing down on the chin there. And once it's in, you can actually just lift up the chin to allow the passage of the iGel around the corner. So by lifting up in that way as best as you can. Bit difficult to do it on one side, but it is possible. But I would find that this is the easiest way to actually do it.
I've heard about people putting their thumb in the mouth to control the tongue and lift up. Is that something that
you can do that as well. So once it's entered the mouth, you can then grab behind the lower teeth, and you holding the tongue as well, and you can actually do it. You actually pass the iGel in that way. Again, it's all about the principle of opening up that area.
I guess that's something we might be more comfortable doing if the patient's got 2 milligrams per kilogram of rocuronium on board, just to make sure they don't bite the thumb off.
Indeed.
And also I've heard about rotation techniques. I know there's some literature comparing, putting it in the kind of right way with an upside down 180, with a go in 90 degrees anti-clockwise, down 90 degrees the other way. I guess these are all ways of navigating past the tongue, aren't they? So you don't fold the tongue up. But the jaw thrust method is going to solve that issue, I
The
think.
jaw thrust generally solves it. However, there can be issues where even when you're doing jaw thrust, and it's a bit difficult to demonstrate on a mannequin, but there's going to be, and if I can go back to this model here, there's going to be, if you look at this model here, you can see there's sort of these gaps down the side, and this area here might be a bit fuller than you want it to be with the tongue. So there is possibilities of not going this way, but actually finding that gap down the side, and then it flips in.
Cool.
Okay, so there is ways of just finding that passage. I would never force it down. If you're forcing it, there's something, if you're forcing it against something, it's not going to go, but you're just trying to find that path of least resistance, and then it flips in.
Nice. In emergency medicine, I find that the commonest thing I'm doing with an iGel is pulling it out to replace it with a field tube. Particularly a patient who has been instrumented pre-hospital with an iGel and then coming in cardiac arrest or post-ROS, and then we're going to intubate the patient. But I guess it probably would be good before doing that to have a troubleshooting algorithm in my mind. So patient comes in, a medic pre-hospital has put an iGel in, there's not much chest rise, there's not much end-tidal CO2, so you're thinking, well, it's in, but it's not working very well. Should I just whip it out, BVM, get ready to intubate, or should I try and adjust that iGel to get a better seal and therefore buy time with a device that's potentially superior to the BVM while I set up for intubation? Any tips you have for troubleshooting and improving an iGel that's already in there?
Look, I think what, as we talked about earlier, maybe the sizing is the actual issue.
Yeah.
So that's obviously quite difficult to change unless you actually change the iGel itself. The position of the iGel, once the iGel is in, even though it's in, you can't see exactly where it's sitting. You could go to the extreme of looking down with a scope through the iGel to see where it's actually sitting. So that's another option. The other option would be to basically release whatever tapes are there and just try and manipulate the iGel itself. But I think that those are the most common things that I would think of.
Brilliant.
Yeah. Just to clarify, Anthony, we do use gel on the iGels?
Yeah, we do use gel on the iGels, just on this part of the iGel to allow it to pass around.
Excellent, thank you.
And thank you so much. That was really useful. I've learned so much, and I look forward to sharing these learning points with other people. And for what it's worth, the viewers need to know that you've taught me so much of what I practice in airway management. I really appreciate that, to the point where I feel a hug coming on. It's comfortable with that.
Absolutely.
Yeah.
Thanks,
you.
and thanks for asking me here. It's and I've learned so much from you over the years.
Oh, guys.
Breath.
This is awesome, isn't it?
That's all, just asking all those questions.
Yeah.
We practiced it all last night.
No, I didn't practice anything last night.
A little child.
These are genuine questions. I'm not making it up. I want to know the answer.
Yeah.